Okay, so good afternoon. My name is Carmen Walker. As a student with Capella University in my last class before graduating with my Bachelor's of Science in Psychology, I am finishing out my psychology capstone project. So for the purposes of this presentation, we will be reviewing ethics in healthcare. The case study that I have selected to review for means of this presentation was case study number 3. This case study involved a school counselor, briefly, whose name was Hannah, a friend of the school counselor who was named Lucia, and the friend's grandmother named Elena. After reviewing this case and I was able to analyze it, I saw that there were several possible issues to address. Firstly, Hannah and Lucia's professional and personal relationship, Elena's grief from losing her husband just 5 years prior, Lucia's concern for her aging grandmother who may be presenting signs of Alzheimer's disease, as well as the doctor's inability to communicate with the patient, being Elena. The patient was Elena, which then leads Lucia to making decisions regarding Elena's healthcare without first discussing it with her. But for the purposes of this presentation, I limited the issues that we will focus to the top 2 main concerns as far as ethics and professional behavior are concerned. So physiological or biological perspectives could help address why the grandmother may be losing her memory after experiencing grief. It could be hypothesized that due to the grandmother's grief, it is greatly impacting her memory. Cognitive psychology theory. But if due to heredity, it could be biological and therefore it would be an unavoidable symptom. However, physiological perspectives could also argue that this is in relation to something that the individual has been exposed, according to Tayano in 2023. An additional theory that could help explain part of the issues addressed in this case study is sociocultural perspective. So this theory would aid in explaining why the doctor would be willing to allow the granddaughter to make healthcare decisions without first consulting the grandmother, the patient, as well as explaining why the granddaughter did not discuss the healthcare needs to her grandmother before proceeding with further testing, further addressing the grandmother's feelings of loss of control. This case study specifically relates to culture-related attitudes that may affect future professional behavior due to the language barrier between Dr. Bandardi, who was an English speaker, and Lucia, who was also an English speaker, and Elena, who was a non-English speaker, but the case study does not specifically state which language she does speak. However, Dr. Bandardi did speak English, but she also spoke English in a thick Indian accent. So even though she spoke English, it made it hard for Lucia to understand her in full. So having an interpreter present would be ideal in future professional settings to ensure that each individual, especially the patient, being Elena, understands what is occurring. Okay, so reviewing the cultural issue here that we kind of discussed on the last slide, this picture is depicted of the Hayes addressing model. So we'll kind of get to that here in just a second, but the patient's nationality severely limited her from being able to communicate with her doctor. So in this case, the granddaughter is forced to step up and attempt to understand the doctor through her thick accent. So upon reviewing Hayes's addressing model from 2001, you can see that the national origin, it gives power to the U.S. born and less power to immigrants and refugees. So it is estimated that roughly 14 million people in the year 1990 had limited English proficiency, or LEP. But it has now been estimated that that number has expanded to roughly 25 million in just 2013, according to Murphy in 2019. This is important and relevant to this case study due to the fact that the patient and doctor were unable to communicate because of the language barrier. Murphy in 2019 stated that caring for patients across language differences is an important component of delivering culturally competent healthcare. The granddaughter, Lucia, was present for this interaction, but due to her not translating the conversation with the doctor, it left the English speakers in power over the situation and gave less power to the grandmother, non-English speaker, which left the grandmother, the patient, without any communication or understanding from her doctor and no understanding regarding her healthcare plan. Now that we kind of have some of the issues addressed and you kind of understand a little bit more about what the case study is and what occurred in there, I would like to address some different perspectives as to why some of these things may have occurred. So first, I want to discuss the physiological or the biological perspective theory, because that can help explain why the grandmother is in fact experiencing memory loss in the first place. It is said that grief is essentially the cost of love. Therefore, at some point in time, we will all experience grief from a human's perspective, and that grief very well may alter our brains, according to Mills in 2022. In a lot of ways, losing a loved one can be described as losing a part of oneself. Mills in 2022 interviewed an individual who stated that when you fall in love, a part of your brain is rewired to include them in your everyday normal activities. It creates a we, not a you and me. It is a team. So this can also be compared to phantom limb syndrome. Grief can be compared to phantom limb syndrome. So where some individuals can feel as though their body is still attached through itching or pain in the missing body part. So Mills in 2022, his interviewee describes a researcher at the University of Colorado Boulder who studies voles, rodents who mate for life. So within this description, the voles become so intertwined throughout their lifetime that when one of them dies, there are physiological changes that are noted in the living vole, and at times it becomes nearly impossible for the vole to return to a normal state, the state prior to the death of the loved vole, which then causes neural and transcription changes in the brain, according to Mills in 2022. So this very well could explain why the grandmother is experiencing memory loss after the loss of her husband, which was just 5 years prior, because this has been an ongoing concern for Lucia and her husband, and it's only gotten worse over time. All right, so moving on to the second perspective. This perspective is one that we can kind of manipulate a little bit more. The last perspective is more just kind of understanding why it's happening. This one is we can kind of dive into it a little bit deeper. So this theory is the socio-cultural perspective theory, which is described as our personality, our beliefs, our attitude, our skills, and our values, according to Tayono in 2023. These attributes shape our culture, our ethnicity, our gender, our religion, and other important socio-cultural factors, which is included but not limited to how people interact. So this would directly be related to this case study due to the fact that Elena's culture taught her to speak a different language than English, and the doctor's culture taught her to speak another language. This means that in this healthcare setting, there are two different cultures meeting, making it difficult for them to communicate. So while they do have the granddaughter there for interpretation purposes, she might choose to not interpret based on her culture beliefs, where she may feel the need to take over the situation or just in general ensure that the elderly in her family receive all the best possible care. This can be frustrating for the patient, and it can lead to other potential ethical dilemmas with this issue, And the culture aspect may explain exactly why it was handled this way, though. The cultures and the ethnicities of the two primary individuals, the doctor and the patient, may have been adversely affected due to their lack of ability to communicate with each other. The doctor's inability to speak the patient's language, and even so speaking English with a thick Indian accent, making it hard for the granddaughter as the interpreter to understand the doctor, which would lead me to believe that even if the doctor did speak the patient's language, she would do so in a thick accent, which could lead to miscommunications anyway. Potential adverse effects caused due to the lack of communication due to the culture, language, and ethnicity barriers may very well contribute to adverse events in the medical treatment of this patient, as well as medical errors, according to Partita in 2007. Even with an interpreter, or with a doctor and interpreter who both speak English, many words can have many different meanings based on which culture you come from. Knowing that a typical health dictionary has between 40,000 and 50,000 words in it, this can still lead to confusion when translated across multiple different cultures, affecting the care that a doctor can give and thus the care that a patient can receive. Looking at what one research study says that was conducted internationally, it was conducted through archival data, and it was based on 14 separate studies that were conducted through various countries. These countries included developed countries as well as developing countries. And with each study utilized approximately 22,000 individuals. This resulted in a total of 300,918 participants throughout the 14 different studies. So each study selected utilized a different approach to collect data. These data collections ranged from interviews to incident reports to questionnaires and even to Medicaid records. The findings from this study concluded that interpreter services were necessary for 43.2% of patient and doctor interactions, and between 21 and 70% of doctors stated that they did not have access to interpreter services, according to Shamsai 2020. Due to the limited access to proper interpreter services, it was analyzed that 30% of the patients had difficulty understanding medical instructions that were given to the patients. 30% of patients had a problem with reliability of information obtained from their medical provider. 49% of patients had trouble understanding a medical problem or emergency communicated from their doctor. 34.7% were confused about the administration or how to properly utilize medication. 15.8% had a negative reaction to medication. And 20% of individuals refused to seek medical attention unless they knew that proper services would be available, because they feared a negative reaction due to improper health care given because of an inability to properly communicate or understand their doctor, according to Shamsai et al. In 2020. There was a second research study conducted that consisted of the onset of memory-related problems after experiencing the death of a loved one. And this was conducted in both 2012 and in 2016. The independent variable of the study was whether or not an individual had experienced the death of a loved one within the past calendar year. A loved one would have consisted of spouses, children, family members, or a close friend, according to Adelaide and Stevana in 2020. Men and women were separated and reviewed separately. However, the final sample included 842 women and 751 men, and all of them were aged between 60 to 85 years of age. Within the span of the 4 years between 2012 and 2016, They observed 69% of women and 67% of men lost their spouse, close friend, or relative, with roughly 30% of the entire population selected having lost their spouse. Overall, based on tests utilized to assess reading levels, working memory, and information processing, over the span of 4 years, there was a standard deviation decline of between 0.07 and 0.13 cognitive decline for men. And the event was concluded to be insignificant for women, according to Adelaide and Stevana in 2020. The speed of information processing for men would decrease by a standard deviation of 0.25, with the effect being significant at 5%, according to Adelaide and Stevana in 2020. In regards to women, the effect was found to be significant in regard to the working memory. Remember that, the working memory. That's what we're reviewing with Elena during this case study, and this is where women would see a decrease in working memory at a decrease of a standard deviation of 0.31. It was additionally concluded that the findings showed a decrease in participation of mental exercises and social engagement activities. However, these have been found to be preventative factors for cognitive decline if they were done. Both of these studies are relevant to this case study because of the fact that the grandmother lost her loved one. She lost her husband within the previous 5 years, and now she's showing a cognitive decline for working memory. The grandmother, Elena, is unable to have a personalized conversation with the doctor discussing these personal issues and home life that may have contributed to her cognitive functional decline. Therefore, treatment she receives may not work as effectively due to the cultural divide between them. Cultural competencies that a psychologist can utilize to resolve this culture-related issue. Now, if we think back to the beginning of this, when we were talking about the case study, we had Hannah, who was the psychologist that was also Lucia's friend. Now, if she were to involve herself in this, she could help in this situation. So a psychologist can utilize cultural competencies to resolve this culture-related issue by advocating and or doing therapy involving a mental health professional who understands the beliefs, the backgrounds, the values, the culture, the race, the ethnicity, the socioeconomic status, and sexuality, according to Salis in 2022. Now, if Hannah is not only Lucia's personal but professional friend, she may very well understand these things and could help in this aspect. Now, the most specific competencies that could be utilized by a psychologist for this issue would be someone who understands the individual's background, their ethnicity, and their values. If the patient, the grandmother, feels understood and is actually understood, she may receive better treatment with fewer mistakes than if she does not. So the principles suggested to fix this issue and prevent reoccurrence in the future is to hire medical providers who have, one, a strong sense of ethics and values. If they don't believe that a patient can properly understand them, they should have the ethical responsibility to state that. Two, self-awareness. Medical providers should have and demonstrate at all times an appreciation for not only their own culture, but others as well. Three, cross-cultural knowledge and skills. Medical providers should regularly utilize a broad knowledge based on different cultures and how to interact with each culture, and when they don't know how to interact, communicate or state that. They should know when to speak up and ask for assistance for their patient. And four, language. Lastly, there should be plenty of interpreters available for patients across a variety of cultures. And these are suggested from the National Association of Social Workers in 2015. These would be competencies necessary for working in a culturally diverse environment, especially the cross-cultural knowledge and skills. By effectively utilizing cultural competence in the workplace, you can not only keep employees engaged, but you can also help keep better communication and coordination with coworkers and clients or patients. And this will help increase engagement and productivity, according to Maryville University in 2023. All right, so addressing the issue. Professional standards that point towards solutions could be translating all medical documents provided to patients. Translators working to translate medical information should have sufficient medical training and knowledge to understand the definitions of medical terminology to give an accurate translation. This would also ensure that the peculiar characteristics of medical jargon is placed in the correct contexts, and it could be ensuring that healthcare workers are not using language that is above the patient's or translator's understanding level, according to Bott in 2022. Additionally, healthcare does have a code of ethics that they abide by. In these situations, the professional standards set forth in the code of ethics requires them to ensure that they remain current on best practices and industry trends. They are also required to ensure patient safety and much more, stated by the National Association of Healthcare Quality in 2023. All right, so repercussions. We're going to dive into this one really quick. So according to the National Association for Healthcare Quality in 2023, it is the healthcare provider's responsibility to ensure that each patient is well taken care of and any potential risk is minimized. So that would mean that if translation or interpreter services are not properly utilized, then there has been documented studies that we can look at that actually state that 30% of patients had difficulty understanding medical instructions, and 15.8% of patients had a negative reaction to a medication due to lack of understanding the instructions or wrong medication prescribed because the patient and doctor could not communicate properly, according to Shamsai in 2020. This can relate to larger societal problems as patients can lose trust in the healthcare system entirely because they are unable or unwilling to provide everything that the patient needs to understand their treatment. Lack of proper translation in healthcare for doctors and patients' communication could additionally take part in the spreading of diseases. If the patient is not able to explain all of their symptoms to their doctor and have them properly understood. According to the APA Ethical Principles of Psychologists and Code of Conduct in 2023, there are a variety of principles and standards that relate to this particular ethical issue in healthcare. Section 1.03 of the Ethical Principles of Psychologists and Code of Conduct in 2023 stated that if an organizational demand presents a conflict between the demands of the organization and ethics, then a psychologist must take steps to resolve the conflict, and it is under no circumstances an excuse for violating human rights. I could directly link this to the healthcare field, as the doctor is responsible for ensuring each patient is seen in a timely manner. However, if a patient requires translation, the process can take much longer. Regardless of the length of time it takes, this is no reason for the doctor to cut the appointment short. Section 2.01b from the Ethical Principles of Psychologists and Code of Conduct in 2023 would additionally play a role in this ethical dilemma as well. Section 2.01b states that where scientific or professional knowledge on a given subject is to be given to another individual, all demographic factors must be understood first. In order for a psychologist to ensure that this is properly handled, they are required to know the boundaries of their competence. They must have proper supervision when necessary, provide competent services or consultations for their patient, or receive the training and education necessary to provide these additional services themselves across multiple fields of diversity. This directly relates to this ethical issue being studied because of the fact that the doctor did not provide a translator or interpreter and could not interpret themselves and did not have proper supervision in this situation while discussing healthcare needs with a family member. An additional section of the Ethical Principles of Psychologists and Code of Conduct in 2023 that would apply to this case would be Section 3.04a. stating that psychologists must take all reasonable steps to avoid harm. The lack of proper translation in a healthcare setting can have very negative and harmful repercussions. This is directly related because if a doctor questions their ability to completely understand the patient, they must make absolute certain before prescribing medications or determining a plan of care to avoid harm. All right. Alternative solutions. If an interpreter was not available, what is an alternative solution? Well, an alternative to resolving this ethical dilemma could be to reschedule the appointment for when there are services more readily available. It would also be wise to ensure that the interpreter is given a schedule of the patient's appointments to avoid having to reschedule conflicts or having scheduling conflicts that would require additional appointment cancellations. However, in the case of an emergency, this may be unavoidable. A possible ramification of this situation could cause a lack of trust in the healthcare facility as the patient does not feel that they are being put in priority. The patient could attempt to seek care from other places and possibly even switch doctors due to the lack of care not provided at one facility. An additional alternative is because the granddaughter does speak English. The doctor could reinforce that the translation being provided to a family member is required to be translated to the patient. Otherwise, a translator would need to be brought in. This lets the family member know that she has a responsibility to ensure that her grandmother gets the proper communication from the doctor from a trusted source. However, a possible ramification is that if the granddaughter does not fully understand the English that is spoken by the doctor, it could be hard for her to provide proper interpretation. This could provide misinformation to be interpreted, and it could make it hard for a proper decision to be made on a care plan. The last alternative for resolving this ethical dilemma is to change doctors. The hospital should take responsibility in ensuring that patients are matched up with doctors that would best fit their needs and backgrounds. This would not provide bias, but would instead provide proper communication and services be administered to patients without the need for additional services to be brought in, or it would not be needed as often. The patient would receive the proper care, and the hospital and doctors would minimize any potential risks. A possible ramification could be that it would potentially overload certain doctors over others, depending on the location you live in. However, more culturally diverse doctors could be hired, ensuring that everyone receives proper treatment and the caseload is properly dispersed over each doctor. All right, so choosing a course of action, I selected as a course of action to add more bilingual doctors, and that would be the most practical as interpreters can be few and far between. And they can also be pulled for multiple other responsibilities throughout the hospital. So while having interpreters in the healthcare setting is vital, ensuring that more bilingual physicians are hired is also essential. Interpreters can be a stranger that a patient would need to bear their private health information to, which can make the care plan harder to assess because maybe the patient withholds information because they're not comfortable speaking with an interpreter, according to the Kent State University in 2017. When patients can speak to healthcare workers in their own languages, they feel more comfortable with their treatment, according to Ivan Novation Language Movement in 2022. According to the Ivan Novation Language Movement in 2022, it has been analyzed that most all medical information for patients to assess and help determine a plan of care is geared toward individuals who are English-speaking adults. They may not fully grasp what is being offered or explained and may decide on a plan of care based on the very limited information which they have. It was found that multilingual physicians in a healthcare field can create better relationships with their patients, and it would be of ethical importance for the physicians to understand the boundaries of their competence, though, and know when to still seek outside support. Okay, so we're going to look at a few different research studies. The first is a study that the data addressed analyzed the characteristics of physicians that varied when they did not speak the patient's language and were forced to find alternative means of reaching a conclusion with the patient. And this was pulled from the Center of Medicare and Medicaid Services in 2017 on page 17. Therefore, it was determined through the course of this study, through utilization of a questionnaire which is appropriate to allow proper translation, that if the physician needed the training, the healthcare facility would be responsible for providing additional language training for physicians, according to the Center of Medicare and Medicaid Services in 2017 on page 17. 70% of respondents in this study indicated that their place of employment provided formal language services for physicians and patients. However, it was determined through the questionnaire that nearly 20% of employers did not have a plan in place whatsoever for language services, according to the Center for Medicare and Medicaid Services in 2017 on page 17. The study's limitations were that few respondents participated in the survey compared to the number of surveys that were actually sent out, and it did not collect any demographic data. So the appropriateness of this survey would be limited to the information that it was able to gain and also what it lacked. The research study aligns with and supports my plan of action because it sheds light on the statistics of what happens when proper language services are not provided to patients. Okay, so the second research study that we're going to look at assesses through categorical and continuous approaches to define how effective bilingualism across different participants, Kremen and Byers-Heinlein in 2021. So some of the ways in which individuals from both monolingual and bilingual backgrounds were analyzed for the course of the study was through the use of questionnaires, which is appropriate to allow proper translation for each participant, which can then be assessed for late learning bilingualism compared to early learning and their varying levels of empirical support. Kremen and Byers-Heinlein, 2021. So late learning was considered after the age of 15 and early learning was considered before the age of 13. This is compared to the continuous model selected as well, where it was believed to be more beneficial to assess an individual's bilingualism attributes or abilities on a continuous model, according to Kremen and Byers-Heinlein in 2021. These methods of study have been found to be effective and appropriate for assessing whether it is of benefit to teach physicians a new language while in medical school or whether to hire an interpreter that has been speaking multiple languages for many years now, which could also be supported by an additional research study that analyzed how the differences in context across languages can affect bilingual speakers and how the languages can influence interpretation by patients, according to Inable et al. In 2017. It is noted that early learning bilingualism was found to lack the emotional foundations for the language, creating a potential dilemma in the interpretation, according to Kremen and Byers-Heinlein in 2021. Emotionality was a common factor for misunderstanding across languages, and brain imaging utilized in the study found that when certain words were stated when using a functional magnetic resonance imaging, an fMRI, individuals who were English native speakers would have different brain reactivity to a word compared to a bilingual whose first language is not English, according to Inable et al. In 2017. This concluded that while an individual may be able to understand a secondary language, the potential for misunderstanding is still very possible through emotions and personality, according to Inable et al. In 2017. This research study directly supports and aligns with my plan of action because a physician that is trained in this information can make educated decisions to better equip themselves to understand potential ways the languages may be misperceived or misjudged by their patients. All right, and so for the third research study, it was conducted through the World Economic Forum, and it was used to assess the cultural diversity among populations from 27 different countries, which included 30,133 individuals, and it proved that on average, 69% of the individuals who participated were from a different country than where they were living. This meant that they also spoke a different language than the country where they resided was their home language, according to Fawn in 2023. The study then compared individual bilingualism and official bilingualism. While it would be ethically more challenging to mandate individual bilingualism, countries with varying languages spoken could reinforce official bilingualism ethically. This would be the ethical way to do it, and there is a legal term. It's called officialization, which would provide legal framework and guidelines for entities wishing to mandate bilingualism throughout their healthcare facilities, according to Fawn in 2023. Official bilingualism is practiced in 34 countries currently, and this study specifically analyzed Canada as one of the countries. Canada has successfully utilized official bilingualism, reinforcing that French and English are the two official languages spoken in the country, according to Fawn in 2023. So ethically, the appropriateness of the study is limited to the languages mostly spoken in those countries. However, by creating two native languages for a country through official bilingualism, the ability for individuals of lower classes of socioeconomic standpoints would be able to learn multiple languages, possibly raising their socioeconomic stands. This method of study was appropriate because it did not hold a bias or judgment over anyone. They were equally utilized, and the research study aligns with and supports my plan of action in the way that it offered an alternative method to ensuring patients are properly understood, as are physicians. The senators and politicians of this country would be the ones to make the decisions based on this argument. However, this study directly relates to my plan of action by adding bilingualism because it reinforces the importance of officials and other important individuals needing to speak multiple languages. So a couple slides back, we did talk a little bit about emotionality. That word was used. So I did just want to kind of touch on that a little bit. So based upon the ethical codes and standards addressed earlier, the plan of action stated in previous slides, the research studies have reviewed phenomena found in a study utilizing questionnaires concerning health literacy and multilingualism. So multiple things were considered in this study. One, potential for words in conflict to be shared across languages. 2, lexical properties can influence an individual's ability to decode documents. 3, emotional valence of words across languages. And 4, any other type of discourse level of text that could potentially influence an individual's reading difficulty. So in conclusion, having multilingual health literacy is of vital importance and could be extended to include multilingual doctors to help enforce the ethical principles necessary in healthcare, according to Esteban et al. In 2022. Individuals for this study were selected through stratified random sampling. So individuals were divided into groups based on their native languages and then selected at random from there. This method of study was appropriate because it did not hold a bias or judgment over anyone, and they were equally utilized. So in conclusion, when addressing patient and physician language barriers, it is important to analyze the possible ramifications of not providing proper interpretation services for both the physician and the patient. A misunderstanding of the care plan can have severe ramifications of the mentality of a patient going into an appointment. If a patient is not able to properly address their concerns, then it is possible for the wrong medication to be administered as well as the wrong dosage, which could have life-threatening consequences if not addressed properly. The need for bilingual physicians is becoming ever more necessary as the United States expands the wealth of languages spoken. Hiring physicians who are bilingual or offering training for physicians that are not bilingual can only increase the physician's personal demand, making their resume more appealing, but can also allow them to facilitate better relationships with their patients and ensuring that they meet all of the ethical standards and codes of conduct through proper care and minimizing harm to anyone they treat. All right, so we have made it to the reference pages, so I just want to thank you for sticking around and participating in my presentation. I just want to say thank you, so have a good day. And here are a few more references, just kind of finishing out the slideshow. So again, I thank you for allowing me to utilize this time and for participating in this discussion.